My main research interest is brain metastasis and lung cancer. And today I want to give an overview on the systemic treatment of patients with brain metastasis that are non-oncogene addicted. And I think you need to realize that brain metastases are becoming a huge problem in non-small cell lung cancer. So if you look at clinical guidelines, screening for brain metastasis is more and more advised. So MRIs and CTs are more and more made, and therefore more asymptomatic brain metastases are detected. And if you look at the percentage of patients with asymptomatic brain metastases around 10-20 years ago, it was around 15 to 16%, and now it's around 30%. So, and if you're aware that your patient has brain metastasis, then you need to decide what you're going to do, whether you're going to treat these patients with systemic therapy or first with local therapy and then proceed with systemic therapy for the extracranial disease. If you look, for example, at the ESMO clinical guideline, then it is stated that in those with asymptomatic brain metastasis, starting with systemic therapy is preferred and that you only give local therapy upon progression on systemic therapy. But you need to be aware that this advice for patients with non-oncogene addicted non-small cell lung cancer is based on subgroup analysis of clinical trials or even very small phase II clinical trials. You need to be aware that most of the phase III clinical trials in non-small cell lung cancer excluded all patients with untreated brain metastases. So usually only those that were pre-treated with radiotherapy and were asymptomatic of steroids were eligible. And only very small trials with chemotherapy have been performed. But importantly, if you look at the chemotherapy trials, then you can see that the response rate in the brain for platinum doublet chemotherapy mirrors the response rate outside of the brain. And we know that if you start with chemotherapy in patients with asymptomatic brain metastasis, then you can defer whole brain radiotherapy or stereotactic radiotherapy in a significant proportion of patients. But now immune checkpoint inhibitors have become the standard of care for almost all patients. If you look at the tumor microenvironment in patients with brain metastasis, then the tumor mutational burden is higher in the brain compared to extracranial disease sites. If you look at PD-L1, then the results are conflicting. But if you then look into more detail, then you can also see that the brain is more often immune ignorant compared to the primary site or to extracranial disease sites. And I think because of the tumor microenvironment, the poor prognosis of patients with brain metastasis, and the fear that the immune checkpoint inhibitors do not reach the brain metastasis or that they reach it but that they cause pseudoprogression, made that most of the phase III randomized clinical trials excluded patients with untreated brain metastasis. However, if you look at the randomized phase III data, usually with patients with treated brain metastasis, and you can see that if you compare it to chemotherapy, patients with brain metastasis also do benefit from the addition of immune checkpoint inhibitors. If you look at the KEYNOTE-189, that's one of the only trials that allowed patients with untreated brain metastasis, but unfortunately, they didn't specify the specific subgroup of patients with untreated brain metastasis to evaluate whether these patients had benefit. There are some single-arm phase II trials evaluating monotherapy immune checkpoint inhibitors in patients with brain metastasis, and I think the most well-known is with monotherapy Pembrolizumab in PD-L1 positive patients. Just over 40 patients were included with a minority PD-L1 negative. And if you look at the intracranial response rate, then it mirrors the extracranial response rate, and it's around 30%. In the small group of patients without PD-L1 expression, the response rate was 0. Importantly, quite a significant percentage of patients had a dissociated response. So either these patients had a response in the brain and progression outside in the brain, or the other way around. But if the patients had a response in the brain, then the response was durable. How to proceed? I think patients with brain metastasis do benefit from immune checkpoint inhibitors, but data for those with untreated brain metastasis are limited and need to be obtained, and several trials, either with monotherapy, immunotherapy, combinations of chemotherapy, immunotherapy, or angiogenesis inhibition and immunotherapy, are ongoing and results are awaited. But as we know that a dissociated response really can occur in the brain, I think in the future we really should focus on trials that measure the response separately. So they measure the response for the brain, but also outside of the brain, and that they really specify in their protocols what is allowed if you have progression in one compartment only. And you can imagine if you have brain progression only, but with a response outside of the brain, then you permit within the clinical trial, for example, radiotherapy or surgery. But I think also as these patients can live quite long, attention should also be paid to long-term toxicity, and usually that's overlooked in clinical trials at the moment. So I think to conclude, brain metastases are a problem in non-small cell lung cancer. They are associated with lower overall survival, but it's important to realize that in selected patients, chemotherapy and immunotherapy can work, and to learn more from these patients, we should have specific trials for these patients with also brain specified outcomes.